looking at the whole literature and some of the research that we had from the lab and some of the translational research that we published, we understood that some of the alkylating agents that we routinely use in primary brain cancers may be uniquely effective in Anne's case because of her phenotype. So that was the key kind of like issue that made the biggest difference. And we have combined that with breast cancer drugs that are not usually first line. So what is going on today is that, and we're trying to kind of like improve on that here at Aurora by the trials and the designs that we're using. When one comes up with a new drug, the big pharma obviously will try to get that drug approved the fastest way possible. So they develop this second line, the third line, the fourth line, whatever line, and everybody after approval thinks that that's probably something that we have to use later or an add-on to already existing therapies. I think is a big issue in terms of, number one, how we think about things, and that is something that is anchored into our routine. And then another issue is, how do we get to think about these drugs, in what way they are presented to us? I would say that big pharma is very good at getting drugs approved, but they are gaming a little bit the system by understanding the short-term endpoints that they have to work with when they design the trials. So I don't blame them for anything. It's just that the hard work would be to actually get some of the better drugs that we have today to be pushed center stage and be used as first line. We actually used a drug that is used for primary brain tumor that we thought was uniquely effective for her disease based on her phenotype. And then we kind of like used second-line drugs for breast cancer in combination with the brain tumor drug. So we kind of like turned things on their head, and it just simply worked because it cleared her brain disease, it cleared her systemic disease, and she has been doing very well, and she didn't need any type of surgery. We could probably, if we adjust things and continue to individualize care, we could probably hope for maybe a decade, maybe a good 10 years where she has full neurologic function. Maybe 30% of the oncology drugs that are used today are used in combinations by physicians that are trying to individualize care. So they come up with their own unique combinations that they think are working for the patient. Not outside of the literature, don't get me wrong, very well anchored in the literature. But trying to push the envelope beyond, one trial or another. That everybody is now in a race to try to understand what are the first, couple of steps that open the door for one malignancy or another. I think that probably in 5 years we will be able to really subgroup the variety of cancers in many, many different subgroups based on the very early genetic mutations that open a door to malignancy. Eventually we will move away from the way we do clinical research today, using the approach based on the current clinical trial design. But we're kind of like looking for one magic bullet for so many different things that are so different. And I think that eventually we'll have to move away from this model and understand a little bit better how we could do this better in terms of individualizing care. But I think this is going to be driven by the knowledge that we will get from, understanding more about tumor genomics and what are the first drivers of malignancy. They are building a lot of momentum in terms of cancer research. And they are really interested in new approaches. They at least don't want to make the same mistakes that other people are making, and want different approaches for cancer. But I think that you will see that very soon there will be big projects in breast, pancreas, melanoma, and brain that will come out from Aurora. They are funding a lot of research, targeted research in the form of grants. They have a structured way for this research where results are expected. I just think that is working. You know, there are a lot of foundations around the country, you know, that are part of different hospital systems. I don't think that they are as effective as Vince Lombardi Foundation. If we come up with a different way to treat patients and enrich the life of our patients, translating that into longer overall survival with better quality of life, yeah, I think that if the foundation has increased the number of patients that have been treated at the hospital on the basis of their research, you know, patients come to us simply because there is basic science research and translational research that has guided them toward Aurora. But I think that the big gains are going to come from understanding how we could combine these drugs in a smart way. Just let me put it in number. If we have 1,000 new breast cancer patients a year, and about 300 of them develop leptomeningeal disease, half of them would not have been treated the way we treat them today unless we actually had the money to look for these two things that we thought would change, and they in fact change, and we now could prove that they change, and on that basis we actually use different treatments, better individualized to these certain situations that keep these patients alive and well for a lot of years. So, you know, a small $25,000 grant is probably going to bring another 100, 150 patients to the hospital and keep them alive for a lot longer. The impact in terms of patient care quality and quality of life, and the impact to the bottom line of the hospital is enormous, as these things will add up in time. And basic science has opened, you know, the door for a certain way of thinking that allowed Dan to have a different option in front of her that I think paid off really, really well.